My name is Stephen Bartels. I'm a professor of medicine at Mass General Brigham and Harvard Medical School, where I direct the Mongan Institute that conducts research on population health and healthcare delivery science with a focus on health equity. So what is the big public health problem? Put simply, despite decades and millions of dollars dedicated to research and public health campaigns on suicide prevention, the tragic fact is that we have failed to decrease the overall suicide rate in the population, and for some subgroups, the rate is actually increasing. How can this be? The answer to this question is complex. There are many factors that contribute to suicide, including those that are outside of what we can do in clinical care. However, it is also the fact that many individuals who commit suicide are patients who are under our care or have recently been seen within our clinics, hospitals, and emergency rooms. So why have we failed? The first is that we have failed to develop accurate and reliable approaches to predicting imminent suicide. The second reason is that even when we have screening tools and identified risk factors, we have failed to systematically implement suicide prediction and prevention interventions into routine practice. Better approaches to predicting suicide are now possible through the use of data science using artificial intelligence and machine learning. So what is implementation science, and why is it important in prevention? Well, for example, we know that on average it takes about 17 years to get only 14% of research into practice. Simply conducting research and publishing results does not necessarily result in improving care. Implementation science is the study and use of strategies that successfully result in the rapid and systematic uptake of research findings into routine practice. Put simply, in suicide prevention, coming up with a better and more accurate tool to predict suicide will not succeed in lowering the tragically high rate of suicide in the United States unless we develop a successful approach to implementing this in routine practice through a variety of different settings, from emergency rooms to primary care and beyond. Among many questions we need to address include: what is the best way in a very busy emergency room setting to make sure that we screen the right people at the right time for risk of suicide? What is the best way to make sure that the results of a tool to predict suicide risk gets immediately communicated to the emergency room clinician? How should the results be communicated, presented, and used? In primary care, the problem is also especially challenging. By a recent estimate, primary care clinicians would require 27 hours per day to provide all guideline-recommended care. How do we add this approach into a very busy and overextended setting of primary care? In addition to considering where and how AI gets used, what are the special needs to adapt our approach to prevent suicide in mental health disparity populations, such as those related to race or ethnicity, disability, sex and gender minorities, age, socioeconomic status, and rural settings? I'm excited to work with the data scientists and clinicians to achieve this goal that will not only make a real difference in reducing the tragic and preventable loss of life due to suicide, but will also contribute to the greater field of prevention science by linking data science and implementation science.